Good afternoon, everybody. This is a new topic, and I just want to say that I was not really aware of what this topic was. It wasn't clear to me, so we put this together literally in 4 days. I didn't know who the fellows were presenting with me, and I didn't know what the topic really was. So it may be a little bit rough, but just realize that, yeah, we got this together pretty much over the weekend. So today we're talking about imaging and patients presenting with chest pain, and this is going to include both patients presenting in the outpatient setting and also in the ED. So first we'll talk about types of chest pain, because the very first assessment in trying to figure out whether or not stress tests or imaging is even needed is to look at the type of chest pain that the patient has and determine whether or not it's cardiac or non-cardiac. Because you're really trying to figure out, is this chest pain predictive of somebody who may have myocardial ischemia? In the new guidelines, the 2021 chest pain guidelines that were updated in 2023, it says, you can see it right there, class 1 indication, chest pain should not be described as atypical because it is not helpful in determining the cause and can be misinterpreted as benign in nature. Instead, chest pain should be described as cardiac, possibly cardiac, or non-cardiac, because these terms are more specific to the potential underlying diagnosis. So on the bottom of this slide, you can see in the red are all the terms that clearly describe somebody who's having cardiac chest pain. In the yellow-green are people who have probably cardiac, not atypical, but probably cardiac chest pain. And in the very far right are those people who have non-cardiac chest pain. So we have cardiac, probably cardiac, non-cardiac chest pain. How does this help us? Because all those people with non-cardiac chest pain, we don't need to do any further evaluation for those guys. We're just focusing on the people with cardiac chest pain and probable cardiac chest pain. So once you've decided that they have cardiac chest pain or probably cardiac chest pain, then you have to predict the pretest probability of them having myocardial ischemia as the etiology of their chest pain. Now, how do we do that? Well, there's two different ways in outpatients and in inpatients. In outpatients, the guidelines recommend the CAD consortium model. And what that does is there's 3 different steps to that model. The basic model literally takes into account just pretest probability based on age, sex, and symptoms. And that's the basic model. The clinical model then adds risk factors. The clinical model plus the coronary artery calcium score then adds the coronary artery calcium score to that. As you can probably surmise, the one that's the most predictive of somebody having myocardial ischemia is the clinical plus coronary artery calcium model, because it more accurately predicts people who have myocardial ischemia on stress testing or obstructive coronary artery disease on anatomic imaging. Now you can see that for stress testing or further imaging in the patient presenting with chest pain, the red circles are there because it's indicating that we should only do it on people who are at least intermediate risk. The lowest patients, we don't really need to do it. The highest patients, they should be getting anatomic imaging. So literally, you can see it's those intermediate risk patients defined as greater than 15% risk on the CAD consortium. And you can see what it looks like when you use the clinical model plus the coronary artery calcium score. That's a coronary artery calcium score between 100 and 999. So you can look this up. You can Google it yourself. You can look under MD calculations. It'll give you this calculator. What does it look like? It asks you these questions. It asks you the age, the sex, what type of chest pain they have. Unfortunately, they're still using the term atypical. It's going to take us a while to get that out of our nomenclature. They're going through some risk factors, and they ask the coronary artery calcium score. In this particular patient, you can see that with the basic model, low risk. With the clinical model, with the risk factors added, low risk. When you add the calcium score of 755, high risk. So who does this pretest probability calculator help the most? Women. Why? Because they were totally underestimated based on their risk when you just used age, sex, and clinical risk factors. So now that you've determined their intermediate risk and you need to do further testing or further imaging, how do you determine which test to use? Because there's so many of them. Well, you have to take into consideration patient-related factors and the imaging or the stress test related factors. The patient-related factors include their age, whether or not they can exercise, either on the treadmill or the bike, whether or not they're obese, whether or not they have drug allergies and drug contraindications, to the things that we use to do the imaging or the stress test, such as adenosine, regadenosine, dobutamine, atropine, iodinated contrast, or gadolinium. You have to take into their account the renal function if you're using the iodinated contrast or the gadolinium. You have to take into account whether or not they have claustrophobia. You need to take into account whether or not it needs to be radiation sparing. And this particularly applies to women of childbearing age. The guidelines specifically say that these people should only receive stress CMR or stress echo. And that's very important for your boards. If they've had prior, you have to take into account whether or not they've had prior inconclusive functional stress testing or prior inconclusive anatomic imaging, because that becomes important in determining what test you're going to order next. And you also have to know whether or not they have a known history of coronary artery disease and or a high coronary artery calcium score. So this is the contraindications of the specific tests. And I know you can't read this. I mean, it's incredible, right? This is straight from the guidelines. But what it's saying is that if somebody has an abnormal resting ECG, abnormal in the way that the ST segments are ST elevation or ST depression, left bundle, LVH with repole abnormality, Wolff-Parkinson-White, you should not order a treadmill stress ECG only on those patients, because you're not going to be able to determine anything because it already is abnormal. If the patient can't exercise to greater than 85% of their maximal predicted heart rate or greater than 5 METs, you shouldn't order that test because it's not going to be accurate because they're not going to reach their heart rate goal. If they're like unstable with like acute coronary syndrome, of course you're not going to order treadmill exercise. You're going to consider pharmacologic or going straight to anatomic imaging. If they have prolonged QT, you're not going to do a treadmill stress ECG because there's an increased risk for torsades in those people. So you're going to just say, no, I can't use this to determine whether or not myocardial ischemia is present. If the blood pressure is greater than or equal to 200 over 110, again, this is a contraindication for any sort of imaging that uses exercise stress testing. And if they have any sort of acute illness like PE or pericarditis or whatever it may be, dissection, of course, you're not going to put them on the treadmill. If you go to the specific imaging modalities, if you go to stress nuclear, so of course, then you have a pharmacologic option. We already talked about the people that you're not going to like put on the treadmill, the contraindications of treadmill. You can put people on the treadmill who just have abnormal resting EKGs, but no other contraindications, because that's the purpose of imaging, right? Because now you have the imaging mode part to like rule in or rule out myocardial ischemia. But it has contraindications with respect to the pharmacologic agent. And those include whether or not you have severe bronchospasm, whether or not you have taken dipyridamole or dipyridamole containing medications, whether or not you've taken methylxanthine, such as caffeine, within 12 hours, and whether or not you have known hypersensitivity adenosine or regadenosine. When we go to stress echo, again, the same contraindications to treadmill stress echo exist, same ones, but there's an additional contraindication. If the images are horrible, of course you can't do stress echo. And what type of patients does that occur in? That occurs in people with bad COPD, other bad intrinsic lung diseases, some obese patients. So in these patients, even with echo contrast, frequently the images are suboptimal and we really cannot see the endocardial border. So you should get a different stress test modality for these patients. The only other things, there are specific contraindications to dobutamine and atropine, which you see here, and they include AFib, and I just realized I missed a contraindication to regadenosine and adenosine, which is your heart blocks, of course, your second and third degree heart blocks, which are listed there. You probably can't see it, but they're there. For dobutamine, it's in patients who have a history of AFib. It's people who, have critical aortic stenosis. It's people who have other acute severe illnesses, people who have LVOT obstruction, people who have glaucoma, myasthenia gravis, obstructive uropathy, gastrointestinal obstruction, all those things, because those are contraindications to atropine, the last ones, dobutamine, the AFib, and the arrhythmias. For stress CMR, what are the contraindications for that? Well, those are people who have a reduced GFR less than 30 because they can't get the gadolinium safely. People who have contraindications to vasodilator administration, like we talked about under stress nuclear. People who have implanted devices, either, like pacemakers and defibrillators, either because they are not CMR compatible or because they're going to give so much artifact that you're not going to be able to answer the question. People who have claustrophobia and people who have taken caffeine within 12 hours. How about CVCTA? What are the contraindications for that? Well, that includes people who have an allergy to iodinated contrast, people who can't cooperate with the breath hold, people who are clinically unstable, people who have renal impairment again, GFR less than 30, people who can't take beta blockers or nitrates for some reasons because we use those during those scans, people who have significant arrhythmias and fast heart rates. Again, we're not going to get good images with CVCTA. So there are more things in this table, but those are the main points. So once you've gone through the patient comorbidities and you've gone through this contraindications, the next part is after that, we'll go through some specific cases where they highlight which cases were used based on the patient factors and the patient comorbidities. In the ED, the calculator that we use is a little bit different. We use the heart score, and you can see that in the ED, the heart score relies on the history, the EKG findings, the age, risk factors, and the initial troponin. And how does that help us? Again, we're trying to identify that high-risk patient that needs to go directly to the cath lab from the intermediate risk patient, which needs further either functional stress testing or anatomic imaging, and then the low-risk patient that doesn't need anything, just needs to be discharged and followed up as an outpatient. When you look at that intermediate risk patient, you see two sides of that pyramid. So the patient who's never had any sort of testing needs testing, is literally what it's saying. The patient who's had prior testing and was deemed to be low risk based on the prior testing, that prior testing within 1 year, and their symptoms are really stable and their EKG is stable, that patient can be safely discharged from the ED and followed up in the outpatient setting for whatever their cardiologist thinks they need at that point. So here again, it's listing in the ED what to do. The low pretest probability, no testing. Follow up with a cardiologist, could get coronary calcium scoring if you wanted to, just to determine their risk better. Intermediate risk, if they're a younger patient and therefore you're not expecting any obstructive CAD, CVCTA is favored. If they're an intermediate or older risk patient, greater than 65 years of age, and you're expecting to have obstructive CAD or a high coronary calcium score, stress testing is favored. And why is CVCTA favored? Because this is probably the only indication where it's favored first. Because of the quick turnaround time in the ED, because quick turnaround time means less money. So if you can get the results of the test quickly and send the patient out and they're not hanging out in the ED or OBS, it's better for the patient, it's better financially. Under this table, you'll see what favors CVCTA and what favors the use of stress imaging. We talked about what the goal is up above. If you have expertise in both, then that doesn't come into play. We talked about age up above. And then if there's prior test results, this is important. If there's a prior functional study that was inconclusive, then you're going to do a CVCTA. If there was a prior CVCTA which is inconclusive, then you're going to do a functional stress test because you're trying to get to the answer and you don't want to order the same test that doesn't give you the answer. And then there's other compelling indications for CVCTA, and that includes anomalous coronary arteries, and also if you're worried about any aortic dissection or a PE, of course you can do the triple UL. There's other compelling indications for stress imaging. That's somebody that maybe the EF is low and you want to see how big the scar is and whether or not they have viability, then you're going to go on to CMR or PET. Or if you're worried that they may have microvascular dysfunction, again, you're going to go on to CMR or PET. And one last word from me about INOCA, because INOCA is different from all of the others. And why is INOCA different? Because there are only two options for INOCA. Either it's an invasive coronary functional testing option, if you happen to have that as a local expertise. That one's favored. Why is that favored? Because it includes more, it allows you to look for more etiologies for the chest pain. It allows you also to look for vasospastic angina, which you can't do with the non-invasive etiologies. If you don't have that expertise, then you have to go on to either PET or CMR with myocardial blood flow reserve. Some centers, you'll see a 2B indication of stress echo, and they're just measuring the coronary flow reserve down the LAD. Again, only certain centers have been able to show that they can actually provide that information. And then you can see based on the PET results, it's going to tell you whether or not it's diagnostic criteria for INOCA or whether with coronary microvascular dysfunction and plus or minus ischemia. All of these elevate their risk for MACE, and the whole purpose of diagnosing this in the first place in individuals It commonly occurs in individuals with diabetes, hypertension, HFpEF, and also infiltrative heart disease. The whole purpose is so that they get that optimal medical therapy that they actually need. Okay, and with that, let's go on to our first case. Dr. Taha is going to present a very interesting case, taking all of this into consideration.
Thank you, Dr. Kohlmeyer, for this excellent introduction. All right, we're going to start with our cases. We have a few cases for you guys, and we do appreciate some participation from the audience, if possible. All right, my case. I have a 55-year-old woman who presented to the cardiology office for risk assessment. She's asymptomatic, she's quite active, she swims about 1 hour a day. She's hypertensive but well controlled on one medication. LDL is in the 140s, normal weight, no strong family history, and calculated 10-year ASCVD risk is 2.5. Overall discussion and decision in the office was to pursue a calcium score. And this is her calcium score results. We see dense calcification in the LAD, some in the circ, and maybe some dense calcification in the RCA. Combined, we have a calcium score of in the mid-700 range. Okay, what would you do next? Optimize medication, CTA, stress nuclear, stress echo, or stress treadmill. Any takers?
I would choose A and 3, 1 and 3, optimize medical therapy and do nuclear stress testing.
Okay, any particular reason to do the stress testing at this point?
She had some sort of anatomical evaluation.
Okay.
And for now, I just want to do functional testing to see if she has like significant disease that's causing ischemia.
Okay. So next, we end up doing a stress test. But it was a stress echo. And those are the results of the stress echo. This is at rest. See any abnormalities there? No, okay. Let's go to the peak images. It's not the best quality. And this was one of the limitations Dr. Kohlmeyer mentioned. Acoustic windows in stress echo is one of the biggest contraindication or limitations. Any abnormalities anyone can describe here at all, if there is any? The one, I don't have the one
Ideally,
side to side, yeah.
ideally, you need the rest stress portion
Yeah.
to be able to compare, right? Because unless the abnormality is very obvious, which you can interpret it because we saw a normal resting,
Yes.
then it becomes very hard, right?
Yeah. So this study was not the most conclusive study, but there was a hint of post-systolic thickening in the basal inferior wall. The rest EKG was more or less unremarkable. The R wave in V3 was not impressive. Peak exercise, also not very concerning. Post-stress, some PVCs. Okay. So we did the stress echo. Would you like to do anything after this or just leave it alone? Anything? No. So she was asymptomatic. Yes.
Conclusive, like it wasn't the best stress cycle. So I think in practice I would do the nuclear stress.
Okay, nuclear stress. What ended up happening here is that
Be careful, you may end up with the same result. right? Because of, if you look at the fine print and if you're in the nuclear laboratory, diaphragmatic attenuation is pretty significant. And there's always what do you call it? An annotation that there's decreased perfusion in the base, but most likely diaphragmatic attenuation. So you may end up with the same thing.
A couple things. First of all, if you go back to the stress echo images, so at the peak, I see the heart rate was like 120, and this is a 55-year-old. So we're acquiring images, not like probably her heart rate really dropped at the time of acquisition. I think that will lower the sensitivity of stress echo, and that's always an issue with exercise echo, stress echo. Now for nuclear, yes, Dr. Zobi is correct if we're not using the newest technology. So if you have stress CT attenuation correction, you should not have that, and that should not be an issue.
Okay, just a few points before you go on. Yeah, the question about the heart rate falling quickly, well, she has excellent heart rate variability because she swims an hour a day. So he did mention that in the history, and we see that. But he did show you the EKG, and the EKG didn't really show us any post-EKG changes, so other than PVCs. I think the most important point here is, yes, somebody mentioned that we have an inconclusive stress test, a functional test. We do have an inconclusive functional stress test. So per the guidelines, when you have an inconclusive functional test, what do you go to next? Anatomic imaging, right? And is there a choice for anatomic imaging up there? She does, and maybe invasive coronary angiogram would have been better, but I think the reason we didn't want to do that is she doesn't have any symptoms, right? So we have an equivocal stress test. We see some post-systolic shortening in the basal inferior wall. And the question is it real or is it not real? She did have some post-stress PVCs, which are a little bit worrisome. So, I mean, you got to pick one, and the question is, which one of those is really the best? Either you're going to do something or you're going to do nothing, and the something has got to be anatomic imaging or optimizing medical therapy, which isn't nothing. It's always a good option.
Dr. Kernmeyer, I have a question. If I do CCTA in this patient, there is a very high chance that it will be read as 50 to 70% lesion in the LAD. And what do I do with that as a next step? Probably I'll have to do angiogram. When I see too much calcifications, to me, the CCTA will not be the most reliable study.
Okay, so yeah, you're right. We'll go ahead with what we did next, is we end up doing a CCTA. And this is the RCA. We can see here mixed calcified and non-calcified plaque, positive and negative remodeling here. More significant in the RCA as compared to the LAD, mostly calcified plaque, and more so than the CIRC, which is probably mild stenosis, if any. CT-FFR was basically positive in the RCA territory. But again, to your point, she was asymptomatic. Now we have functional and anatomical evaluation. Decision at the time was to optimize her medication and leave her be. Okay. Subsequent encounter. After 8 years, she presented with recent onset, 2 to 3 months exertional chest pain. She used to swim daily for 1 hour, but lately quit swimming due to this new onset pain. Pain is central, retrosternally located, pressure-like, no radiation, improves with rest, and associated with exertional shortness of breath and palpitation. Those are the main risk factors we already mentioned, the high calcium score, and the most recent LDL after optimizing medical therapy was 50 from 140s. So what do you do next? I gave it away. We end up, because we have a baseline test, we elected to do the same test, but gladly this one was a better quality one. So those are the rest images. We can see good wall motion, no wall motion abnormalities at rest. I don't have the rest to peak comparison, but this is the peak stress. Anyone would like to give a comment on this? Dr. Zolvi.
All right. I mentioned that before for you, but you always compare rest to stress. And the reason for it is not only for the regional abnormalities to see what really happened to size of the ventricle, function overall, in addition to regional function. You can't interpret these studies like this. You really cannot. Okay? Unless you have an impressive segmental wall motion abnormality that stands out. So, from my recollection of what the images were before, there may be a little tardokinesis in the inferior base, but not too impressive. Really, it's not too impressive. So I don't know how much she exercised. The heart rate here is 57, so I don't know, you know, here, what is this, 100?
This is 105, but she did reach her like 90% predicted heart rate.
Yeah. Did she have EKG changes?
So this is at rest. No, this is at rest. And this is at peak, wasn't the best, but we see like kind of bigeminy going on.
Yeah.
And this is at recovery. Any thoughts, guys, on this EKG changes?
I mean, interesting, EKG-wise, you're not seeing ischemia. And remember, in women, you see it more frequently. That's why sensitivity is high, specificity is low, right? And I'm not seeing a heightened sensitivity, although her history is very suggestive of
Right.
angina. And you have to respect that in a way, with some couplets there, etc. So
Yeah.
anyway, it's not horrible ischemia. So if you were not treating her with anti-anginals, you may want to treat her with anti-anginals
Yeah.
and see what happens.
Okay. Well, given all the combined picture of high calcification, she used to do very well, but now very limited. She's quite active. We have two inconclusive stress echoes with prior positive CTA. Decision at the time was to pursue with CT angiography. So as we here see that the LAD just probably moderately diseased, CERT looks okay. And this is the RCA. We have like 90-95% stenosis in the mid-RCA. And eventually it was intervened on with good results and symptomatic improvement from the patient standpoint. All right. So going back to the pretest probability Dr. Kohlmeyer mentioned before, when we put our patient in perspective, all the risk factors, we find that she meet the intermediate to high pretest probability, especially in the presence of high calcium score. And we put it in the CAD consortium, we see that the risk was almost 73% for an obstructive coronary disease. Guidelines mention that we go with either CTA or functional evaluation for intermediate to high risk stable chest pain patient. We went with actually both of them. Went to use either. When one was inconclusive, we went for the other test. If I want to add one more thing on these differentials or what favors one over the other, we always can get calcium score with stress MPI and myocardial blood flow with a stress PET. This is the pathway we used in our patient. So she was intermediate to high risk. We went for stress imaging. When the stress imaging was inconclusive, we went for CTA and eventually invasive angiography. Those are the contraindication for stress echo. Dr. Kohlmeyer already covered those. And few take-home messages. In my opinion, was stress testing or CTA not highly recommended for asymptomatic patients, because for 8 years, it was not the best to risk stratify our patient. Stable chest pain with intermediate to high pretest probability might need a further testing. Choosing CTA versus stress test should be patient-centered. And regardless of what you choose, optimal medical therapy is the #1 priority. I'm gonna give it next to Dr. Toro.
Thank you, thank you. Good afternoon, everyone. So this patient is Mr. G. He's a 8-year-old patient, medical history extensive of type 2 diabetes, controlled, hypertension, hyperlipidemia, previous smoker. Initially presented to the clinic in 2019 with mild chest pain and exertional symptoms. Now his PCP before being referred to cardiology ordered a calcium score, and it was 1464, so pretty elevated. This is his initial EKG. Anyone would like to comment? First years. I love you all, so I'm not gonna point fingers. Try to not to be mean. Come on. And some LVH. Okay. And if there is T changes after LVH, mention that. Other than that, you get dinged in the coding. Okay, so I'm not going to put the echo images, but the echo was ordered, and the results were pretty just normal diastolic dysfunction, grade 1. Let's see the next one. Okay, so this is what we talked about. When we look at the patient coming with chest pain, no known CAD, we have to stratify what is the risk. And I think the main message is if the risk is low, just treat medically and defer any testing. When it's come to intermediate and high risk, it's pretty much the same. So practically, I would say this 15%, you can look at this old model and stratify, but the new CAD consortium is probably give you a better idea. And I think practically is this 15%. If it's less than that, then you don't need to do anything. And this is basically the question first of, based on this, what do you think, guys, we should do next? Exercise ECG, SPECT. Yeah. Okay, that's a decent thought. Medical therapy. Some testing. I mean, so the score is 87. 15%, no, it's not. I mean, it's pretty high. I mean, ex-smoker, diabetes, hypertension, all the package. And 1460 calcium score. So CVCTA, I don't think I will order that. Probably there's a lot of blooming artifact and we'll be able to get the result that I need. And as you mentioned, there's some LVH and some changes, so probably wouldn't exercise the patient. And the patient was 85, so I don't know how much he's gonna exercise. So we proceed with the SPECT. That was the, if you go with this algorithm, you see the patient's probably high intermediate risk, and based on the profile, you'll probably go with the functional testing. So this is the SPECT imaging. Second years were not yet into PET. This one pharmacological, sir. I don't know what exactly the rationale was. It wasn't mentioned in the note. I didn't see the patient, but I presume that's the reason.
Remember, exercise whenever you can. Always, no matter what test. Exercise, you get the functional capacity, which by itself is a prognosticator. 2, you get what happens to the electrocardiogram, because what happens with the electrocardiogram in any pharmacological agent is really not diagnostic. It's just specific, but certainly not sensitive, right? Symptoms, you can also forget. So if somebody can exercise, I mean, I understand the age, but age is not a contraindication for exercise, right?
If someone can. Okay, so as you mentioned, there was no, the stress was very normal. So after 2 years, the patient started having more chest pain. And to give a little bit of addendum to the story, he presented actually to the emergency department with worsening chest pain, and he was admitted for a non-STEMI. Now, the EKG is not included. I looked at it, wasn't much of a change, but the troponins peak around 200, and he has a little bit of AKI. So what's to do next? A little bit of AKI, creatinine 1.2, 1.3. I heard PET. Okay, he did have a PET scan. So this is the PET scan. Any takers? I'm on PET, but I know the easiest question to answer is when you know the answer. Any takers? 30 years. Oh, I have 30 years, my friends. Smita, I saw you. I can give you more data if you need. There are all the things you need in the PET. It's subtle, to be honest. I didn't see it when I read it.
Maybe
but
some
I read the
basal
report.
antroceptal, maybe. And is there some TID? I'm not sure.
So TID was 1.13,
Okay, so it's like borderline. It's like-
borderline, correct.
yeah, and then
So
basal
the polar maps didn't call it, but there was a 6% to 8% inferior defect around the apical area.
If you look on the third row, the third image from your left, the inferior infraseptal. So with PET, you have to read it with more sensitivity because images are attenuation corrected. If you look at the apex, so if you look on the second row from the bottom and the middle of it, you see there is decreased counts in the apex compared to the one in the last row. So he has at least 2 vessel ischemia.
The polar maps didn't call it, sir.
That's why we have a jump.
I was like, damn it. So the EF also didn't increase, actually decreased from 72 to 70. And the calcium score was much higher compared to 3 years ago. Now what I have with the flow data, the rest flows were not low, but the peak flows were actually all decreased in all territories. And the reserve was pretty low in all coronary artery territories. So this is the report, the reading. We discussed all of it. And based on that, the patient went to a cath. And here's the moment of truth. Let's display it. My intervention friends. Someone. Sorry, I can't hear you. Yeah, so left main. Correct. And this is the one after. I'll give you some images. So this is a better image of the LAD, and this is the circ wasn't bad. And now we're going to show you the RCA, pretty bad osteal RCA disease. So left main, around 60-70%, mid LAD, significant lesion, and then osteal RCA. Now, the patient elected actually to go into a PCI. His STS score wasn't high, and I tried to learn what Dr. Koshnavis told me about syntax score. So it was around 20 when I calculated. So it's an intermediate risk. So basically, this patient can go with both. And I think at 85, probably it was reasonable to go with PCI. So he got so far PCI to the OCL-RCA and then to the middle AD lesion. The left main hasn't yet intervened on, but his symptoms significantly improved. I think the main take message that I learned from reviewing the guidelines is the low risk category. I think we probably have to have a little bit more courage to say we can treat medically and don't test more. Because I think even testing, a lot of time we get into issues, and sometimes even, I won't say we do harm, but a lot of patients get things that probably not needed. And yeah, that's the case.
Right.
Questions, concerns? Thank you.
I suspect also that on his first SPECT study, he had ischemia that was not detected. Because, I mean, this is a lesson for all of you, because not necessarily that we've been burned, but you need to know that in a regular SPECT, since you don't have flow reserve and amount of flow that you can have with PET, the images will look good and your polar map would look normal. One, there are two things that can help you. One, the history that you have to go, and you have to decide for yourself whether to, pursue it further. The other that I always look for, although you would think it is not important, you always look at the electrocardiogram, particularly when you suspect ischemia. And this is where you'll have a major discordance. Even on pharmacological stress testing, when you have triple vessel disease or left main, you'll have significant ST depression with normal looking SPECT. So always keep that in mind, because actually you may not do your patient any service if you miss it.
Thank you, sir.
Correct. Good afternoon, everyone. So this is a patient, 59-year-old guy with a medical history of, you can't, okay, let's see. Okay. So this is a 59-year-old guy with a medical history of smoking, hypertension, and pre-diabetes who presented to emergency department with chest pain. Chest pain is ongoing for 6 days. Recurrent, mid-sternal, sharp, radiates to the jawline, worse with lying flat and better when he sits up. It's non-exertional, lasts for a few minutes, and resolves spontaneously. What do you think about this chest pain? Is it cardiac or non-cardiac chest pain, based on the guidelines? Exactly, right? It's somewhere in between ischemic or pericarditis kind of a chest pain. So this is his EKG. Class 1 indication for chest pain. What do you think about this EKG? Sinus and some T-wave inversions in the inferior leads, right? Okay. Baseline labs unremarkable. Troponins are flat. NT-proBNP is within normal limits. This is his chest X-ray. What do you think? Some vascular congestion, right? Mild. Nothing remarkable. So let me go quickly through this. All right. So person with a cardiac chest pain, EKG with some T-wave changes, normal troponins, chest X-ray with some vascular congestion, right? Just before going toward these sophisticated risk calculators, what is your clinical judgment? What do you think? Where does he fall? Is it a low-risk cardiac patient, intermediate, or high-risk cardiac patient? Taha?
So based on the risk factors, he had multiple traditional cardiovascular risk factors for
Right.
sure, including smoking, hypertension. But for description, I would say it's low to intermediate risk. It's not like a high risk for obstructive coronary disease.
Okay.
So put him oval or maybe moderate.
Moderate to intermediate risk,
Yeah.
at least intermediate
Yes.
risk, right? Okay, so as Dr. Korelmine mentioned, there are several clinical decision pathways calculators that have been recommended in just guidelines. The most simple one is the HEART pathway, which involves the age, clinical risk factors, EKG, and troponins. And it has a categorization for the intermediate and high risk, as well as the low risk. So this is particular risk calculation is not for this patient, but if we calculate it on ourselves, I would basically call history moderately suspicion, give a score of 1. EKG non-specific T waves changes 1, 2. Age 45 to 64, that takes 1. Risk factors 1 to 2, risk factors 1. And then troponins, which are normal, 1. So it is still at 6 at the intermediate risk, which is basically 4 to 6. So I'm not going through these guidelines. So now you have this intermediate risk category patient presented with a chest pain. What do you want to do next? We have discussed several stress testing modalities here. What do you feel? And then I'll tell you what we did here. So some T-wave changes on the EKG, right? That kind of takes exercise, stress test, but any other exercise modality, right? Any other exercise modality. Okay, let me see if it is still working. Imaging. Okay, so this is his SPECT, but it was a nuclear regadence stress test. It's very marked abnormality, right, on the stress test. What do you think? Wait a second here.
Looks like mid-to-basal infralateral scar, right? Looks like mid-to-basal infralateral scar.
So it's a fixed defect, but there is some reversibility, right? To a degree, some reversibility. So now, with all this context and this imaging, what do you think should be the next step here?
What was the calcium score with this?
2.
No, I know, I read this patient.
Why are you asking, Mark?
Yeah, one vessel.
At this stage of the game, you know, calcium score not gonna take me up or down. I mean, even if it is 1700, I'm gonna have to interpret it this way unless we're getting biased. I mean, at times it could be 0 and somebody who's on the younger edge and, you know, not calcified. The question is you
there is
have an
a-
abnormality to start
No,
with.
what I'm saying is the calcium score in this young patient, I think I may have, there was a recent case that I was involved in. It may hint you to non-CAD scar, especially that there were like some discussion about being calcium score of 2, very less likely to have obstructive. You need to do coronary anatomy. This is not, with this scan, you need to have a coronary anatomy. You may do it non-invasive with a calcium score of 2, but it sounds like this may be a non-CAD scar. So we see a lot, but that comes after looking at coronary anatomy.
So for this one, I don't understand why a CVCTA wasn't done. Because this is somebody that we didn't have any known history of CAD. He's in the ED. We determined he's intermediate risk based on the heart score. He's sitting there. There's no, he's less than 65. we don't have a calcium score, but, you know, he's less than 65, so presumably it's not high to, you know, to affect the interpretation of the CVCTA. So I don't understand why he went for functional testing rather than just getting a CVCTA.
That's a very valid point. I think CTA would have been helpful in this patient. What was his heart score?
6.
Yeah, so our protocol here that was crafted by the ER, if they are 3 to 6, they get testing, and they usually start with coronary CT. We start with calcium score. If the calcium score is low, we continue with the CTA. If the calcium score is high, they got shifted to functional testing. Maybe a weekend case. I mean, I'm just to say why, because on the weekend we don't offer CTA, so maybe that was the reason.
Okay. So you are like,
But when we test, when we do an MPI, at what point I would say I can treat medically this patient versus I move to angiography?
For this patient, he has no known history of CAD, and now you're looking at a fixed perfusion defect, which one of the, number 1 to 10 differential is myocardial infarction. So you need to know what's a differential. So you need to know why this patient infarcted. We still don't know. Treat medically what? I don't know what I'm
No,
dealing
not this
with.
case, but in general, when I read, let's say sometimes 7%, 8% ischemia and distal RCA. Can I do just medical treatment? I mean, at what point when I'm interpreting SPECT studies?
So the
or
old
PET
data
studies-
suggested less than 10% you can go with medical therapy, but again, I take it with full nuances. So this is data that was gathered in 1990 to 2000. So there was no calcification, there is no blood flow data, it was primarily the perfusion defect. That's what you had. Now, 7% ischemia and the 4,000 calcium score in a symptomatic patient is very different than 7% ischemia in a young patient with a calcium score of 2. So you have to look at the entire picture and not just one number, and otherwise machine learning will figure out what to do with patient.
Okay.
okay.
Thank
So I like the report. The report was very interesting. So basically, it shared the study quality is poor due to marked attenuation artifact, which vary between stress and rest, and in the setting of calcium score of 2, we should proceed with CTA. In my humble opinion, I think we should have just gone to the coronary angiogram, but what do you think? Yeah. Yeah. Yeah.
Fifty to 60, I mean.
Yeah.
No, I mean, the way I think about it is a CTA and an intracoronary injection, both of them give you similar data. Both of them give you similar data with dye injections, with one of them maybe adding calcifications and others outside. So in this individual, you already are pursuing another test. And the question is, why are you pursuing the other test, right? We have a perfusion defect that is most likely ischemic on top of a previous infarction or just severe ischemia that you see some of that. And then a clinical syndrome that needs further investigation. If I do a CTA versus an intracoronary injection where I'm planning conceivably an intervention, it would make sense to bypass a CTA, right? Because the probability of having an obstructed lesion is very high.
Yeah.
So the question for yourself is, am I gonna treat this individual medically already with the information that I have? Or most likely I'm gonna lean towards a revascularization for either the symptoms or some salvage.
Complications here. In this particular case, from a bird's eye view, is that most likely, given the low calcium score and the fact that SPECT as a modality tends to have diaphragmatic attenuation, is why it pushed the ordering physician or everything towards getting another non-invasive anatomical testing. But if we were very confident with the SPECT imaging, and say we had a interpretive calcium score of maybe 100 or 200, you'd have directly jumped to cath, is what I think happened in this situation.
But correct me if I'm wrong, where the attenuation is an unusual attenuation because the lateral wall is also involved, right? It's a posterolateral as opposed to the inferior diaphragmatic area, right?
So what the reader was implying here is that even it looks like, if I'm looking at this correctly, the reader felt even the attenuation correction that was done, because the second row is an attenuation corrected image.
Yeah.
And the reader felt that it didn't do a good job, maybe because of something related to the quality of the images or the quality of the CT that was acquired. So, I mean, the reader just didn't want to leave it as scarred. He or she was implying that there is something more here that you need to pursue further. So,
But remember, the reader doesn't have the whole clinical picture. So what I'm saying to you, the reader may suggest whatever they're going to suggest. And it's up to the clinician ultimately to say, this is the situation, I'm going to lean towards either the recommendation or something else. Because you have the whole picture, including what happened to troponins, what's the clinical syndrome, right? And it is up to you, the clinician, ultimately to get this, follow the recommendation or not.
Okay, so the CTA was done, and it shows marked abnormalities. You have mid-LAD severe stenosis. We have severe mid-sex stenosis and mild disease in RCA. And FFR was positive in the circ, and there is, if you see, there is a CTO or the loss of further demarcation for LAD. So we have coronary angiogram. So we have severe circ lesion in the middle. LAD CTO. And RCA mild disease. So this patient eventually received cabbage. No, pre-diabetes. Hi. So in a frame 3 trial, cabbage was not actually superior to the PCI, and because it has a mortality benefit, Dr. Chang, and symptom relief too. So Dr. Chang, there was a patient-level meta-analysis in Lancet. I can send you the paper, which basically showed revascularization with cabbage was associated with mortality benefit with or without diabetes.
But also, I mean, to be fair, this is not an ischemia patient. Ischemia excluded patients with recent ACS or recent hospital stay. So, I mean, with all, like, I think if somebody, this is not probably done for, like, the mortality benefit may not be as high as if it was left main or very proximal LAD, but it probably, there is symptom relief in it, and a lot of the revascularizations are done mostly for symptom.
Pre-diabetes. True. However, there, I mean, he came in with an ACS-like picture in the ED. That was his first presentation. I mean, we call it unstable angina, right? I don't.
Okay, so this is a very young guy, right? How old was he?
It's
59. So he's a very young guy, and you're right. It's not cabbage versus PCI. It's you have both of those in your toolbox, and you're just trying to figure out when are you going to use the right one at the right time. The right time is when the patient is at lowest risk to receive the one that's at highest risk. The highest risk procedure here is a CAB. It's not a PCI. He's going to have coronary artery disease the rest of his life. You can guarantee. He's only 59. So at this point, it makes sense clinically. He's having symptoms. He's got a large scar. He's got a lot of disease, that you would pull out the CAB card because you're offering him revascularization, complete revascularization. So you'd pull out that CAB card with optimal medical therapy. Does that mean that's all he's going to need? No. Further down the road, he's going to need PCIs and all this other stuff because he's a young guy. Now, it would be different if he was 80, right? If he was 80, his STS score is going to be much higher because it's age-based. So then you would be like, okay, maybe not so much a CAB for this 80-year-old. It depends on all his other comorbidities and that STS score. But he didn't give us the STS score here, but I guarantee it's low. So you would say in the 80-year-old, no, I don't think I'm going to do CAB. I think I'm going to do multivessel PCI to relieve his symptoms. Dr. Bergler, do you have anything else to add? We have to remember here too that on the echo, he's got normal wall motion. So we know that that's still alive.
But I don't think we have tested if he's ischemic or not for simple reason, because we have SPECT, which is only showing the worst lesion, and happened to be in this patient, the worst affected territory was the LCX. So if you really want, you can get either PET or stress CMR and look for that territory for the LAD. I don't think we've tested ischemia in the LAD.
Yeah, I agree. All we have is the echo showing the normal wall motion.
Sorry, what was? Yeah, I mean, I think he'd be ischemic.
No, but you do have normal wall motion based on your SPECT, and you also have normal wall motion based on your echo. I know we haven't looked at viability or all that other stuff, but you do have normal wall motion there. So that really is telling you that it's probably still alive.
Yeah, but I agree with Sumin. Maybe just go ahead and fix the circ and do CTO PCI and buy time, because most likely this patient is going to come 10 years down the road or 5 years down the road with another stenosis, and then you can do bypass at that time. The choice of revascularization is a separate discussion, whether he needs revascularization or not. I think he needs revascularization. The modality may be debatable, whether you want to do 2-vessel PCI versus just bypass.
I agree with you, Moaz. It comes down to a discussion with the patient, you know, and between the patient and his clinician, and you could say, listen, you've got a lot of disease. At some point, you're probably going to need a bypass. You know, if you do it now, it's going to be less of a risk just based on your age. If you do it later, it's going to be a little bit higher risk. And, you know, it's a shared decision making. That's it.
I don't care what happens. You know, I just want a PCI. We would go to our CTO expert, Dr. Shah, and he could pick through the LAD if necessary. My own personal belief, and Dr. Shah will be mad I said this, but if you gave me a choice between picking through 100% LAD and doing a Lima to the LAD, and you ask me in all probability which one is going to require more procedures down the road, he would probably say they're equivalent. I'd probably say personally, I think the Lima to the LAD, the odds are that that's probably going to stay longer than than picking through the CTO. That's just my opinion.
Okay. Well, thank you, Safi. Thank you for that very interesting case.